we have been posting both the slides and the recording on the Maine CDC website, if you're aware of anybody who wants to take a look at that. So I'm going to go ahead and share screen. Did you guys get a thing saying it's recording? Because yeah, okay, great, thanks. I guess it just doesn't show here. So I am going to just start here. So the updates this time around related to the vaccine. A couple new things on the vaccines, checking in about implications of Omicron and changes that it's making to the antibody therapies, and then some of the newer therapeutics Dr. Benowitz will run through. So the new things on vaccines, really about boosters now being authorized for younger people and at 5 months, and then the third dose for immunocompromised. So just spell them out here a little bit more. So now Pfizer booster specifically for 12 and older, which can be given at 5 months for everybody. So not just for the 12 and older, but for everybody. Moderna now, just as of last week, also booster can be given at 5 months, although that's still for adults. J&J stays the same, 18 at 2 months. And then that third shot for immunocompromised 5 to 11-year-olds is also new. Additionally, CDC, you might have seen last week, changed their language, or maybe updated their language. So, so now using the language fully vaccinated means that they've completed their initial series, whatever it is, and then using the term up to date to mean fully vaccinated, and that the individual has received whatever boosters are recommended for their age group. So it is admittedly a little tough to stay on top of it, but that's the language right now. Somebody is fully vaccinated when they complete their initial series, and they're up to date when they've got their recommended boosters. Just off to the side, Isaac, Dr. Sears is still texting me saying he's not getting it. So I don't know, maybe you want to text it too. So there's a nice resource from the FDA. I've got the link and the graphic here, just showing in terms of who's eligible for both the initial series and boosters with age groups. And again, when we post these, the link is live. So a nice tool for practices. So the big message really is promoting those booster shots, particularly in the setting of Omicron now. So governor's vaccine website is the best resource for that. I pulled out a couple of here, but it is changing all the time. So don't quote me, and be sure to check the website. The key there, I understand that there's a lot on that website, but the key is to search by county and just go through all the pages. But Augusta Armory remains open, importantly, for boosters and walk-ins several days a week. Auburn Mall in Portland, Maine Health has been running appointments, offering boosters by appointment and original series. Northern Light Health, I believe that's reopened now at Pier 1. And then I believe, yeah, no, that's right. Yeah. And then York County EMA as well. But there's certainly, all the retail pharmacies as well, but continuing to try to push those as much as possible. Because as we know, Omicron is fully here. So the latest data that we have supports the presence of Omicron as the predominant strain now, and certainly you all know the implications of that in terms of higher transmissibility, possibly, maybe, probably now less disease severity, but escape from some of the therapeutics that are out there. So we really need to just continue to promote the basics, and then we'll talk just a minute about the implications. Thinking about now the array of therapeutics, and again, I'm going to turn to Dr. Benowitz in just a minute. I'm just going to talk about the monoclonals. I would point out that Maine CDC has put out 2 important HANs. I'm going to put in the chat when I'm done this, or Amy, if you've got a minute, or Isaac, if you've got access to it, the website. I know we look to the HANs to get information out. Not everybody gets it. So if you haven't signed up for a HAN, there's a website where you can sign up for it, but the HANs are posted at the link I've got here. And again, 2 have gone out just recently. So I encourage you all as clinicians to sign up for those. Big news in terms of Omicron now that we are seeing that it's more than 80% here in Maine, estimated at more than 95% in the country nationally, is because it does not work against Regencov and Bamedi. Unfortunately, starting this week, we're telling sites not to use those two monoclonals, and we're suspending allocations and ordering this week. So we're left with sotrovimab, which does appear to still be effective against Omicron. However, it's for treatment only and not for post-exposure prophylaxis. So we really do not have an option right now for post-exposure prophylaxis of known close contacts. And it is only administered via IV infusion. So is obviously a limiting issue in terms of monoclonal antibody providers that have been offering sub-Q injection, not able to use sotrovimab for that. So we're, while we've promoted monoclonals heavily, we've got some significant challenges with that. Limited doses of sotrovimab. We literally are getting between, we just heard this week, 80, and last week was 140 or so doses. So not very many doses statewide. It does have a longer window of when they can be given, the 10 days versus what you'll remember some of the other therapeutics. We do try to maintain that list of infusion sites online and keep updating that, but definitely some challenges. So I'm going to switch it here to Dr. Benowitz to pick up on the long-acting Evusheld and then the oral therapeutics.
Great, thanks, Lisa. So some of this is information that we've shared previously, but worth a recap. So the first drug that I'm talking about here is Evusheld, which is the long-acting antibody for pre-exposure prophylaxis. This was authorized about a little over a month ago, and this is just for adults and pediatric patients that are moderately to severely immunocompromised who are not expected to mount an adequate immune response following vaccination. Those folks should still get vaccination, but following vaccination, they will become eligible to get this long-acting treatment that is expected to last for about 6 months. The supply is highly constrained. We're only getting about 400 doses per month, and so we are distributing those through 5 institutions across the state, mostly sites that treat larger numbers of cancer patients, given that most of the highly immunocompromised patients are transplant or cancer patients, as well as some immunodeficiencies. The next drugs that I wanted to talk about, and sorry, the last thing I wanted to mention about Evusheld is that in the health alert that we sent out a few days ago, there is a link in there that gives a little bit more information about which conditions currently qualify in the top tier for getting Evusheld, and points of contact for the 5 centers where you can connect your patients to get that treatment or get them in line. Moving on to the next slide. We now have 2 oral antivirals that are available for COVID outpatients with mild to moderate illness. These are Paxlovid and Malnupirovir. Paxlovid, it can be given to adults and children 12 and older who are at least 40 kilos, patients who are at high risk for progression to severe COVID. And it's 85 to 90% effective against hospitalization or death when given within 5 days of symptom onset, and it's given as a treatment over 5 days. The second one, Malnupirovir, also a helpful addition to the arsenal, but not nearly as effective. So this one can only be given to adults 18 and older. It is contraindicated in pregnancy, and it gives about a 30% reduction in hospitalization or death. So as I mentioned, still really valuable, but not nearly as helpful as Paxlovid. These 2 drugs are, go ahead to the next slide, Lisa. So these 2 drugs are also in highly constrained amounts at this point, and we're making them available just through 2 retail pharmacy chains, a handful of stores from Walmart and a handful of stores of Hannaford. And so those links up there that you can also find through those chain pharmacies' websites give you a list of the stores that have the drug in stock. It is getting used up quite quickly. There are also 2 federally qualified health centers that are getting a small number of doses of Paxlovid and Malnupirovir, but those are really intended for the primary patients of those health centers. The one thing that I really want to highlight about these oral drugs, as well as the monoclonals, is that they're only available under FDA emergency use authorization, which means that they simply cannot be prescribed to patients who do not meet the emergency use authorization criteria. I'm not going to review those extensively here, except to say that the expectation is that clinicians adhere to those details. We're already hearing occasional reports of patients getting prescriptions for Paxlovid or Malnupirovir who don't have COVID or don't have appropriate risk factors as delineated in the EUA. There is no such thing as off-label prescribing for drugs available under EUA. The expectation is that you adhere quite closely, and we ask that you do that to ensure that we get these drugs to the patients who truly need them. Go ahead. And then the other thing that I wanted to highlight, and this is really probably in some ways our most valuable addition to the arsenal in recent weeks, Remdessevier, which has been FDA approved for treatment of COVID-19 in hospitalized patients. There was a recent study in the New England Journal looking at Remdessevier given as an IV infusion over 3 days in the outpatient setting, and it showed, this slide says good results, but it's really incredibly promising and helpful results. The trial showed an 87% reduction in hospitalization or death. And so this really puts Remdessevier in the same ballpark as Paxlovid and the monoclonals. This is off-label use. There has been some concern around the insurance coverage of it, but there's now a CMS J code, which should be really helpful in terms of sort of establishing those coverage pathways. And really, I would think about Remdessevier as your primary option because this is the one where we have the most supply. Go ahead. I think I shared this slide the last time we met, but just to highlight, we've got really constrained supplies for the oral antivirals as well as the one remaining monoclonal. We recognize that that the current approach is somewhat fragmented in terms of where patients can access these. And we are having some internal discussions right now this week to figure out which patients these drugs should be restricted to ensure that we can get them to the patients that need them most in the setting of supply. Next slide. This is a somewhat complex looking Therapeutics Decision Aid put out by the Office of the Assistant Secretary for Preparedness and Response from HHS. And it really just goes through some of the basic criteria in terms of who can get sotrovimab, remdesivir, Paxlovid, and Malnupirovir based on how far out they are from onset, how severe their symptoms are, age, and then also some important considerations around pregnancy, renal disease, and hepatic disease. Right now, we are not asking anyone to restrict the prescribing of any of these drugs beyond what's specified in their emergency use authorizations. However, we're considering a number of different approaches to prioritization to ensure that we can get these to the most vulnerable patients. You may have seen the NIH interim statement on patient prioritization, which prioritizes moderately to severely immunocompromised and unvaccinated patients over vaccinated patients, and that is simply based on risk for progression to severe disease and death. We anticipate that we will be putting out more information in the next week or so regarding which of these patients can and cannot receive these drugs at this time. Next slide. All right, back to you, Lisa.
That's it. Yeah. So to open it up for questions, I think I saw some things coming into chat. Amy, you want to tee those up?
Well, I don't see any chat questions yet. I put in the links to the.
Oh, okay. Sorry, I couldn't see the chat. Oh, okay. Open it up for questions. Anybody want to unmute? Or Dr. Sears, sorry for the joining problems. Anything you want to add from observation?
No, I think I heard Isaac and he's clearly given a very complete coverage of this topic, but it continues to move. And maybe tomorrow morning my Zoom will work. Who knows?
Dr. Sears, one question I've been getting from clinicians is last Wednesday at the press conference, Dr. Shaw talked about doing oropharyngeal swabs versus nasal swabs for COVID testing. And so the question is that the new recommended approach, or what's the CDC's position on that?
Very good question. And I know there's lots of conversation. Where does it come from? It comes from some studies, but they're not very big studies, but there's suggestions that Omicron specifically is more in the oropharynx than the nasopharynx, and that might be a better way of getting a specimen. It's not yet an official recommendation. It's that, if you do it, that's okay. I think we'll get more data. I don't know whether, Isaac, you've seen anything more that's out on this at the moment, but I've not seen anything that says go ahead and that this is the preferred at this point.
Yeah, so at this time, we're going to ask that people continue to use those rapid tests the way that they're actually FDA authorized, which is to say that if something is listed as only being used for nasopharyngeal swabs, that you only use it with nasopharyngeal swabs. We recognize that this could lead to a brief theoretical delay in detection of the Omicron variant, in particular over the Delta variant. And we're working as hard as we can to identify or create data showing whether these can work via oropharyngeal swabbing. But right now, we just don't know enough information to be able to recommend using these in a way other than how they're actually described and written and authorized.
I think it's important to recognize there are some tests that use saliva, and that's because that's the way they are authorized. This is only for limited numbers of tests at this point.
Okay. I also put in the chat back to the HAN issue. Isaac, you would put the links to the recent HANs. Thank you. And then I just put the link to register to receive HANs if you do not already. Other questions, what folks are hearing out there? Questions from your colleagues or patients? Okay. Well, I imagine that there are still lots of opportunities for education and questions. So as you hear them, feel free to send them our way. We have said we would wrap up these sessions when things stop changing. Hasn't happened yet, but maybe we're getting close. I don't know. We'll see. Right now, we are still saying that we will hold them monthly, which I think I just had on the last slide, whatever that the second Tuesday of February is. So if there are no more questions, we will plan to sign off. Last minute, anybody want to? Seeing somebody just signed on, but nope. Okay.
Lisa, sorry.
No.
Lisa, this is Deb Fournier. Just a quick question clinically for long-term care residents who we know have been exposed to COVID positive patients. We have been using, as you know, the monoclonals prophylactically. Is there any option for us at this point? What's the recommendation?
So at this point, the recommendation is to only use sotrovimab among the monoclonals and to discontinue use of Bamedi and Regencov. That unfortunately means that there are no remaining options for post-exposure prophylaxis. This is certainly a hot topic and a challenging one because it means sort of shifting our thinking. But the other thing that I've heard sort of brought up again and again in these discussions is that there are simply no data on treating a patient with more than one of these anti-COVID therapies, which means that if you did treat someone with one of these other monoclonals that really has activity against Delta and little to no activity against Omicron, then the patient developed disease because they more likely were actually exposed to Omicron. There would be clinical concerns around giving them one of the other highly effective therapies that we have once they develop disease.
Okay, thank you. And then I have one other question. It might be more of a regulatory question, but you mentioned the definition was changed recently for fully vaccinated now, meaning that's up to date. Do you expect or anticipate that there'll be regulatory changes that match that with requirements for vaccine? Or is that unknown at this point?
That's unknown at this point. I will say that right now there are no regulatory changes or planned regulatory changes. However, particularly in healthcare settings, if you look at the guidance that US CDC put out and that we mirror from about 3 weeks ago, looking at healthcare worker essentially quarantine and isolation. This is from December 23rd from US CDC, looking at when healthcare workers should be restricted from the workplace after exposure and when they can return after infection. It essentially endorses that you set a much higher standard for healthcare workers who are not boosted. And so I'm not sure whether that means that the writing is on the wall across the board, but I would ask everyone to just be aware of the different expectations for quarantine and isolation for healthcare personnel.
Okay, thank you.
Dr. Benowitz, can you talk a little bit more about the use of remdesivir as an outpatient? What would be the clinical indications for that?
Yeah, so thanks, Amy. So really for all of these drugs, for sotrovimab, remdesivir, Paxlovid, and Malnupirovir, I think about them the same way, which is that these are intended for patients who have clinical risk factors for progression to severe COVID and have mild to moderate COVID-19 illness. And so the differences in which of those I would pick are based on supply and access. So remdesivir is the one that we have the most of currently, and it's not being controlled by the state. And so it's available in some clinical settings, and hopefully we'll be getting more information about which ones those are. But it's more widely available, including likely at many of the sites that have hopefully at increasing numbers of sites that have previously been offering the monoclonals. Sotrovimab is going to continue to be offered at some of the sites that have been offering monoclonals. And then Paxlovid and Malnupirovir, of course, are oral drugs. So you don't need to be in an infusion center, but they are currently just available across pharmacies around the state. So one thing I would highlight is that remdesivir is an IV infusion given over 3 days. And so you really need a patient to be not just within the first 7 days after symptom onset, but also be able to return 3 days in a row. There are simply no data for using remdesivir in an outpatient setting in a sort of pattern other than 3 days in a row IV. And so, if you have a patient who is days 8 through 10 after symptom onset, then they wouldn't be able to get remdesivir, which has only been studied within the first 7 days. So a patient who's day 8 through 10, I would think more about sotrovimab. And if you have a patient who you have concerns about them being able to return 3 days in a row for the additional doses of remdesivir, then I would think about Paxlovid or potentially Malnupirovir, because they're 5-day oral courses, but you just dispense them once and the patient finishes it at home.
And just to underscore that or follow that up, the issue of needing to be able to infuse for 3 days in a row clearly has been a challenge for many of the sites in terms of staffing. It's already an issue for some to be able to do sotrovimab IV versus sub-Q. So we are, as Dr. Benowitz said, definitely trying to track down who's actually able to do that, even though the supply is a constraint right now. The staffing, as with everything healthcare right now, is a challenge. So. All right. Anybody else? Okay. Well, thanks everybody for your attention this morning. And right now we'll plan to be back in February, and I suspect things will continue to evolve. Sign up for those on, so stay tuned. Thanks. Bye-bye.